G'day everyone, this is my video for the third year guide. You won't see me around uni this year because I'm on RCS in Bunbury. I'll give you some tips on hopefully trying to get into RCS if that's what you want, but third year might be slightly late to be getting on that bandwagon now, but that's okay. So third year, the short and skinny of it is that the first 6 months are the exact same as second year, and then it gets a bit crazy in the last half. So I'm not going to really say anything about the first half. You understand how that works. You've seen my video from second year. You guys have just done second year. So you still have PBLs, you still have clinical skills, you still have OSKIs, you still have lectures. So it's the same thing. Second half, you have what's called SRS. So that's student run seminars. So how SRS works is that you're split up into groups of 3 or 4, and so that might make 28, 30 of you, groups, and then you're each given a topic and you're each paired with a clinician. So you guys have to make a presentation, a series of case triggers to put up on the whiteboard and give on the projector and give to everyone in the room. So everyone in the room will be sitting in their little groups of 4, and then they'll be going through the case, basically the same as a PBL, but there's no tutors with you, they're just roaming the room. So let's say you have a case on palliative care, because that's what I got. Your first trigger will be, old mate John has presented with really bad epigastric pain and weight loss for the past 3 months, and now he started vomiting up blood and he's gone to the ED. Then everyone around the room will do their, what do I think it is, my differentials, what investigations, what questions do I want? You guys all understand that from PBL. So it's very similar to PBL. So you do your case triggers, and then you will move into some questions. So that's to make people think. And so obviously for that first trigger example I've just given, you probably write on your next slide, what's your top differential? And people might be going, pancreatic cancer, colon cancer, varices. You obviously don't know what it is yet. And so people are giving all sorts of differentials, which is great. And then the clinician might talk about it. So you give them the mic and then they go, so this is a really common presentation. Lots of things like this happen all the time. We see this a lot in ED, and then you move on to your next trigger. And then you keep going through, and then you can have a quiz at the end or something like that. My top tip for when you're making this is please make it fun, because these tend to be very boring if the group does a terrible job. And so, in ours we added a role play, like breaking bad news to the family members. One person wanted cancer treatment, one person wanted to palliate, and then we got people in their groups to be arguing about it. And it actually, people are actually enjoying it. If not, people are doing it for fun. If someone's not getting something out of it, at least they're still engaged, okay? Because just going through triggers when you've done it for the last 2 years can be boring. It is. So make it interactive. There was one where it was a really good case. It was an emergency case, and then you had to type in something into a website to try and get lab results back, so your patient had collapsed, and then you typed into the website. If you type the correct term like D-dimer, it might come back with a D-dimer result. You type in ECG, and it comes up with the ECG, and then you have to pick the diagnosis and pick your treatment. So that was a fun case because one of the group members has collapsed on the floor, and you have to demonstrate. So that sounds like a fun case to you guys, I hope, because that's about as fun as they're going to get. And if everyone's is like that, everyone will really look forward to doing. SRS. So cahoots, role plays, dramatizations. Don't really care. Doesn't matter what it is. Just keep it upbeat, interesting. Videos, anything to make it that it's not just death by PowerPoint. And because it will be for some people if they don't do that. And obviously the tutors love it as well, because you want to be keeping it going and being something interesting. So top SRS point is that keep it interesting. And it kind of equals PBL. How many of these are you doing a week? You're probably doing 2 to 3, okay? But there's no follow-up. So, with PBL, you come back the second week and you discuss. With SRS, there is no discussion. You might have seminars related to it, you might not. So it's really just boom, 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 boom throughout the whole second half of the year. So you can imagine that you're having 2 to 3 PBLs a week worth of content to have a look over. And not all of that is supported by seminars. Not all of that is supported, is content that's given to you on a platter. You obviously understand how the med school works now. So you have to do your own learning. Now what's great about it, and I'll show you in a sec, I made up a master document of all the SRSs we got. They'll obviously be different. Is that of your 10 or so LOs that you get, they've moved away from giving you LOs. They used to, but now they don't want us to put too much, emphasis on them. I just put the case into ChatGPT and then get it to give me 10 or so LOs. That way I have, sort of a scaffold to go off. Or if they don't give you the LOs, they might give you 4 or 5 dot points to go off. But what's great about, if you've done your Anki or some other form of keeping up throughout the last 2 years, is that the first 10, there's the 10 dot points, maybe the first 3 or 4 or 5, you've already done to a high level, and then you're just polishing. So this is a lot more management. So with these cases, you should be able to go, oh yes, my next, my next step for this arrhythmia is to give amiodarone 300 milligrams IV. So that way, when you're ready for your 4th year and you're going into the clinical world, you can give these answers like that, because the clinicians obviously don't really care about the pathophys as much now. They care a lot more about management, recognizing the cases. And so that's what you should put your mind to is, if I saw this case, could I manage it? And that's a really good A/B test to see if you know enough. So let's say you saw, I saw, what did I see yesterday? Saw ringworm. Let's say if you saw ringworm, so tinea corporis, in the clinic, you need to know that topical terbinafine or something like that is the first line treatment cream for it, what it looks like, how to describe it on the notes. Okay, that's the level you need to be at for all of these SRSs. Obviously some are a lot more in depth than others, especially the neuro ones. But yeah, you get it. So management is the priority, is takeaway. I really like to work off management principles, because obviously the drugs change. So I want you to think about it in terms of principles, because you can take away, you can just look up things on ETG, but you should understand that, if they've got a fungal skin infection, then they probably need antifungals. If they've got some arrhythmia, they need this. And then recognizing the cases is also good, like all the stroke ones. What else? Yeah, it does get overwhelming. And my tip for that is, let's say that there's, because obviously doing 2 or 3 PBLs a week is a lot. Let's say that you've done 2 of the 3 for that week and you can't keep up, skip it. Okay? They don't build on each other, the cases. They don't, so most of them don't build on each other. Like you don't see stroke 1 week and then stroke 2 where it's building off the principles on the one before. It's like, it could be like stroke and then skin or something like that. So if you skip it now, then you can stay up to date. And then in that 2-week break at the end, just before your exams, you can look over it then when you're a bit less worried about keeping up. So my top tip is to stay keeping up. Oh no. I guess I have to go home and change my shirt before placement now. So do that, and then yeah, so just stay on top of it. I've even skipped whole weeks because there was stuff going on, and then I came back and learnt it later. You have, in the first sem, you have MSK and Neuro, as there might be something else. I don't know, you'll figure it out what they are. You understand how the system works. MSK is a lot. Hopefully you've kept up from MetaNat. If you have, it makes it a lot easier. If you haven't, it makes it a lot harder. For MSK, my favorite Anki deck is the Blue Link anatomy deck. And it's just got all cadaver images, so you can use that. For Neuro, I like the, let's see what it's called. It is called Core Radiology deck. It's an Anking deck. I like it for everything, and I've spoken about it before. The Core Radiology deck is great because it's got all of the neuro imaging presentations on there. So that's great for that. Yeah, it's a real step up from second year, but you've already got the principles in place, I hope, and you can keep going forward. For PBL and for SRS, try to stay up to date, try and keep it interesting. What else? And then obviously you've got your OSKIs at the end of the year. Let's talk about OSKIs because they're important, obviously a must pass. Let's talk about the bread and butter histories. So my top tip for histories is practice, 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 practice. And I like to do that by using ChatGPT, the voice mode. It works great when you're driving home. If you just train it, you can go, let's do a practice presentation on a cardiovascular, practice history on cardiovascular presentation. And then it'll act out as the patient. I don't know what they have, they could have pericarditis or something. And then you take the history while you're driving or, just sitting there. And then you can work through that. And my top tip here is something that's caught me out for my OSKI, and I lost a lot of marks because of it, is not my presentation. My presentations were great of the cases. Well, I think they were. Is giving differentials. So please practice giving 3 to 4 differentials at the end of every case. Today I saw Mr. George presenting with a constrictive chest pain that's worse when he leans forward and leans over his knees. It's worse when he takes a deep breath in. His medical history is notable for a recent upper respiratory tract infection. No medications of note and no family history of note. My top differential is pericarditis, viral pericarditis. Could also be myocardial infarction and perhaps a vasospastic angina because he said he had smoked or something. So as great as perhaps that summary was, if I don't give those 4 differentials, you lose marks. And you lose marks every differential you don't give. So if you give 1, that's a mark. But then if you just give 1, it doesn't matter if it's the most obvious case of something. If you just give that 1 differential, you'll lose marks because you haven't given 3 or 4 more. So just practice giving differentials from day dot. So that's something because we only got told a week or 2 before, maybe a week before the OSKI, and then it wasn't embedded in my head enough, and I didn't do it properly for all the stations. And that being an excuse as it may be, that's something that I felt I would have liked to know at the start of the year. So if your histories, practice them, practice taking good notes while looking at the patient, practice your summaries, and practice giving good differentials. You can even throw in management there if you want. It's a good practice for 4th year. So there's that. And then for your actual exams, you learn all the exams. They're not any different to doing them in 2nd year, 1st year. My favourite way to remember them is that I'll give it to someone in 3rd year, is that I've made a Anki deck so that I can do them, I made up a specific card type, and so that I can do them in the, I chunk them. So how I chunk them is, let's go shoulder. So there's obviously all your intro stuff, and then I chunk it into look, feel, mood, specials. So I first remember all the headings. So I'd remember I'd have a flashcard that would just be what are the headings of the shoulder exam. And so then I'd just go, oh, intro, look, feel, move, special tests, conclude. So that's how I remember the headings. And this is important because, well, this is just my approach, right? You can do it however you want. But I think this works great because when I go into the exam, and let's say that when I'm doing look, I forget to comment on, I don't know, skin color or something, any bruising. That's a lot better, but like at least I know to still look and mention things that I've seen rather than just missing the entire look section entirely. It's very easy under the pressure of an OSKI to miss an entire special test, it's like just not do any. And because their marking key, from what I understand, is very similar to this in the fact that they just give marks on a column under each heading, basically. And so, you know, their marking key might be, I'll give full marks if they've done 3 or more looking observations. You know, give full marks if they've done 2 or more special tests. And then obviously the examiners, they're not curtain examiners. They're not curtain tutors, all of them. So they don't see exactly how you're meant to learn it. And they just look at it in the sense of how they'd expect a third year medical student to perform in the hospital. So there's things that they might have missed, that you might have missed, but they still would give you full marks just because you hit that heading. And that's a great thing to remember for all of your tests, and even for your histories. I'll give you a history template that I like to use in a sec as well, just now that I remember. So, and then I have flashcards that are, you know, what comes under intro, what comes under look, feel, move, etc. And then that way I can just go into all the exams and I already know the headings that I write on my paper at the start, and then I write down things that I usually forget under each heading. That way I can check in the exam and look down and go, oh, you know, I've forgotten this. Let me come back and do this quickly. Same for your histories, you need to give a nice conclusion as well as some differentials. I need to take a drink of water and filming videos all morning. Accidentally paused my other camera, so we'll get back into it. For my histories, I like to write this on my piece of paper every time, and then that way it keeps me going throughout the history. And I might have showed this in another video, I can't remember, but this is how I do it. I write name, I write age, I sometimes write date of birth, and I like to write gender just because they're kind of expecting you, not all examiners are, but some of them will give you extra marks if you go, you know, do you identify as male, female, what are your pronouns, etc. Then I go here, I go presenting complaint, then I can write my presenting complaint across there. I like to do ICE, E, straight away, because it gives me nice time to do some nice open questions before, because as we understand it, when we're doing history, it's very much a spiraling in, wider, 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 to tighten in on our diagnosis. And so if I can have a nice wide, these are wide questions, and so they hang out here on the outside of that spiral, versus your Socrates and things like that, which hang out, you know, closer in. It helps me narrow down first, and it saves me time on the consult. And they're really good questions to build rapport with the patient because you're actually caring about, you know, what's going on with them. So ideas, concerns, expectations, and effect on life. Big point, because this is a great question to ask because it, you know, say they come in with elbow pain, until I ask maybe 10, 15 questions later, if I go, oh, what's the effect on life? And they go, oh, like, I can't even pick up a water bottle. And I already know that that is a serious elbow issue versus, you know, them going, oh, I just can't hit as good a forehand in tennis. So that's why I use that. And then I like to write down here, Socrates. You all know how to use Socrates. Even if it's like something like fatigue, which is a really non-specific presentation, I still have it on the page because you don't know what you're walking into. And I like to, you know, go on set, you know, what's the characteristic of your fatigue? Is it morning? Is it night? Like, when does it happen? So even though it's for pain, it works well for other stuff just to keep you thinking of it. Timing, out of 10, you know, things that make it better or worse. I think you can see it down here, yeah. I like to write ample. So allergies, medications, past medical history. This is for like ED, but it works great for this for me. So past medical history, so allergies, medications, past medical history. Last meal, which I sometimes swap out for travel, it just works for me. But that's, you know, for your anesthetic history and trauma. I just have it in there anyway. And then the E, that's events in the lead up. So for me, that's also a chance to ask about things that happened in the lead up to this. Was there any big life events? Was there any things happening in family? Did you travel anywhere? That sort of thing. And then over here, I write SNAP. So smoking, nutrition, activity, and then I write like family, so SNAP. And then if you understand the rest of the mnemonic, you can write that in there as well. And figure out something for the U there. So I use SNAP, and then over here, I'll write my DDX. I usually put my DDX here on the page. And then over here, I write my red flags. So I sort of go through it like this. So flow down here, summarize here. That way it's almost a hard knock for me to summarize. So I summarize there, in between my history, and I can ask some focus questions in there. Obviously this is just a structure. And then I summarize to the patient and then go through their ample, their SNAP, their red flags, summarize again, and all the while, even in their presenting complaint, I'm writing on here my differentials. And then that way, when it comes to summarizing later, I've got the differentials there on the page, and then it's also really easy to just cross them off or write a new one. So that's my little structure, and so this all fits on a page on the little books that they give you. Even if you do one line of thing and you leave like a little space, it fits perfect on there. So that's what I use for OSKIs. I don't really think there's much else like I can give you, except for start a screen recording, and I'll go over how I keep a track of what goes on in the SRS. So you get given this big master document of all the SRSs. So there's 29 for us, right? And you might have more, you might have less. So when I do it, I look at the 2025. Well, I managed to get some of the content from the 2024 students and managed to line them up a little bit. In the end, I didn't actually really use this because I didn't really pre-read ahead too much, because it kind of gets away from you the time, and it's almost easier to just do the study just like directly after the SRS, because then you know what to look for. So I personally wouldn't get the previous year stuff because it seems like a lot of it was random. Like there was some stuff that lined up, but then for example down here there's 1, 2, 3, 4 there's like 4 things that didn't line up, so it doesn't all line up. So I write it in here, and this is free form. You can use OneNote or whatever. I put my LOs here, and then as I'm going through the LOs, I will later in the year I'll tick them off with a green line, or I used, what did I use? Tick boxes or something. So that's how I do it there. That's how I keep track of what I've done. And as you can see, most things are green. And then over here, I got AI to make these. These are pretty good actually, and it's going to be a lot better now. I got it to make me management flowcharts based on Australian guidelines, color coded, and it's done really well. So I did that with ChatGPT. I think I used research, but it'll be able to do this now because it's gotten a lot better since that time last year. So I put them over here for some of these things. So I mean, I still use this one often. This was the breast mass one, and so it was actually a lot better than the ones I could find on the breast screen website, as well as the screening timeline. It can make all this, so it's all out there. You just have to be able to use it. So I track what I need to do in here by using photos of the learning objectives or LOs that ChatGPT has made me because they don't give them. I also was tracking what I've done throughout the year at different points, and then also some of the student groups give master documents like this one, which I really enjoyed. Some of them give nothing or nothing useful. So yeah, obviously this one's missing an LO because that was mine. And then I like to write in things that I want to read up on as well, like snake bites and toxicology and the management of that. It wasn't something we covered, but it was something I wanted to read up on, and I'm glad I did because it's come up for me since then. So yeah, that's how I keep track of everything. There isn't really any need to look at past year's discussion questions, LOs, pre-reading and stuff like that, because it changes quite a lot between each group, and it's just not, I didn't find it useful at all. So don't really pester the year fours for it because it just doesn't help you. That's what I'd say for that. And obviously if you want to read up on it ahead, there's a lot of these things are quite easy to read up on, in sense of pediatrics and a rash. Obviously that's going to be all the erythemas, that's going to be measles, that's going to be, so you can read up on it. And so that's how you do it. Testicular pain, what could it be? It's probably torsion, could be cancer. So you can read ahead a little bit if you want, do a bit of pre-reading, but don't do too much pre-reading because you'd see that a lot of these when you go in are completely not what you think. So that's my tips there. Otherwise, have fun during the year. It's good. It's not easy, but it's definitely the start before you get into clinical year. So enjoy the fact that you don't have any responsibilities yet. Enjoy your placements that you do. GP, make the most of it. Depends on whether you get a good GP or not. There's not much you can do if you don't, but you can sit there and go, I wouldn't do that. Why did you miss that? That sort of thing as well. Hospital placements, it's luck of the draw, so you get anywhere. It might be good, it might not be. When it comes to hospital placements, it's really what you make it. I was on a placement and the ward was completely dead. There was nothing happening. And so, there was visiting specialties to the ward, and I just asked them, hey, can I follow along with you guys? And they're asking me questions and things like that. Obviously, I impressed them enough for them to give me their number and just ask where they were the next day, and then I could follow them around. And I learnt a lot from that. So hospital placements is what you make it. If you just want to be a wallflower and sit in the corner, you can do that. And if you don't want to be and you want to do something fun, ask, and then you shall receive. Just be keen. Enjoy it. when it comes to your clinical exam, like things like doing cannulas and things like that on patients, be confident. You'll either get it in or you won't, and not being confident isn't going to help you, get it in. So yeah, just, be humble about it, but also be a little bit, got to have some confidence behind you. That way your hand's not going like this. It still will, but what can you do about it? And as long as the patient's given consent for everything that you do in the hospital, you'll be okay. And that's especially important for things like surgery. So if the surgeon or someone asks you to do a DRE and the patient hasn't given you consent specifically, you probably shouldn't be doing that. Things like that do happen when, the students bow under pressure to the surgeon, but you shouldn't be doing that unless you've been given consent. So yeah, consent's everything in the hospital. Enjoy your placements. If you want to do RCS, get involved in the rural things, and then, have a chat to Keith or someone like that who's involved in the RCS, and chat to them, and then they'll give you things to do to try and get on it. They do a background check on you. So if the uni is not happy with you as a student, they're not going to let you go to RCS, because there's a lot more responsibility than in the hospitals, and there's not as much supervision. So you need to be a good student for them to trust you that you're going to be safe to do, good things for RCS, and you need to reflect well on the uni. They'll do a background check on you. You need to show interest in rural things. You need to be, members of the clubs, etc. Where should you go? Anywhere. Sure, you could argue some sites are better than others because they're a teaching hospital or whatever. But at this stage, we're really just learning the basics of clinical management of patients and talking to them. And so you can learn that anywhere, because sure, you want to manage extreme cool cases, you want to see cool stuff, but if you can't talk to the patient, take a history, put a cannula in, do some basic bloods, know how to manage the basic presentations, how can you manage the more acute things that you're going to see later in your career? So get really good at the basics, and you can do that anywhere you are, whether that's Warren Blackwood or whether that's, Bunbury. And interviews for it, they're not that hard. They're just chatting to you, see how you are. I guess if they have any concerns with you, they'll bring them up. I know people were asked, if they've got a wife and kids, like, how are you going to manage, that sort of thing. So and RCS so far, it's been really great. I haven't had anyone say anything bad about it, so I would recommend, if you can get away from Perth, to do it. You guys know how to contact me. If you don't, my student number is 21504282. So just shoot me an email if you have any questions. I'll be happy to answer it. Check out my blog. It's got some cool stuff on there. You can find it from my website, patricklee.com.au. And so it's got some cool stuff for Anki on there, like installing the Anki Terminator plugin, which is like a ChatGPT AI right next to your Anki while you're doing reviews. And so you don't have to type in your questions. Have fun for the year, guys. And thanks for watching.